Hello guys, uh, we will start with the case. A 67-year-old man who comes to a physician with 3 month history of fatigue. He has no distress but show marked pallor, multiple pinpoint non-blanching spots on extremities. The spleen is enlarged. The lab study shows decreased hemoglobin, increased leukocyte count and decreased platelets. The blood smear shows immature cells with large prominent nucleoli and pink elongated needle-shaped cytoplasmic inclusions. So what's your diagnosis? Let's see the key points here. There is anemia, that's pallor. There are multiple petechial hemorrhages. There is splenomegaly. There is increased WBC count. And there is needle-like inclusion in cytoplasm, which are known as OR rods. So this all points towards the diagnosis, that is acute myeloid leukemia. So it's a leukemia, indicating that it is a cancer of white cells, right? Acute, here the cells are immature. Myeloid, cells are of myeloid lineage. So it is, what happens in AML is the immature cells of myeloid lineage comes under circulation in peripheral blood and marrow. You can find it on these two places, right? So let's see its definition. It is a heterogeneous group of diseases where peripheral blood and bone marrow is infiltrated with malignant cells of hematopoietic system, that too of myeloid lineage. So myeloid lineage have the precursor for RBCs, platelets, monocytes and granulocytes. So there will be inability to mature by these cells. So the precursor of these cells, the immature precursor, will be seen in circulation, and thereby RBCs, platelets will count will be reduced. So if you see here the picture of normal bone marrow versus AML, so you can see here there are more blast cells. The criteria is more than 20% blast cell. Okay. This is how you make differentiation between it. And you will see there is less of the mature cells. Okay. Coming to etiology, the most common cause is idiopathic. It is associated with several chromosomal disorders like Down syndrome. Down syndrome in young is more likely to cause ALL, whereas in adults it is more likely to cause ALL. Patau syndrome and Klinefelter syndrome are also known to cause AML. There are certain diseases where there is bone marrow suppression and which later on results in acute myeloid leukemia. So the cases like Fanconi anemia, dyskeratosis congenita, Schwarzman-Diamond syndrome, Costman syndrome, Diamond-Blackfan syndrome, all these are known to cause AML. In Costman syndrome, there is congenital neutropenia. Bloom syndrome and ataxia telangiectasia, there is defective DNA repair, which can also cause AML. Other causes like radiation exposure, chemotherapy involving alkylating agent, topoisomerase, inhibitor. So this 2 inhibitor can also lead to blood cancers, including acute myeloid leukemia. The next is people associated with plastic and rubber industry are also known for AML. There are some genetic mutation. Very important mutation is PLD3 gene mutation. PLD3 is PMS like tyrosine kinase 3 mutation. So this mutation is having comparatively bad prognosis. Unfortunately, this is a common one. Other mutations are NPM1 mutation, CEBPA mutation, and c-KIT mutation. These all are having comparatively good prognosis. So coming to clinical feature, the age. So mostly old age is affected more. The median age is 67 years. Gender, males are affected more than females. The most common clinical feature which will the patient present is fatigue. So there is anemia, so the patient will have pallor. The increased WBC will cause leukostasis, which can manifest as ocular problems like blindness. And it can also hamper brain function. Can also be hampered. There is decreased platelets, so it will cause increased tendency to bleed. So the patient will present as with epistaxis, or like in our case there was petechiae. Or there can be unusual side bleeding. Liver and spleen are enlarged, so the patient will complain of early satiety because they will feel fullness. M3 is associated with DIC, and M5 variety is associated with gum hypertrophy with bleeding. So coming to classification, M0 is undifferentiated AML, M1 is with minimal maturation, M2 is with some maturation, M3 is acute promyelocytic leukemia, also known as APL. It is associated with translocation 1517, which leads to formation of RARA protein. Also, it is most associated with, or rod is most common with M3 variety. Then other translocations are 821, which is more commonly seen in type 2, translocation 1616, and inversion 16. So these are the three other chromosomal translocations which can lead to AML. This M4 acute myelomonocytic leukemia, M5 acute monocytic leukemia, M6 acute erythroid leukemia, and this one is the only which is pass positive among all, and M7 acute megakaryocytic leukemia, which is associated with Down syndrome. Other than this, it is CD41 and CD61 positive. So the investigation of choice is bone marrow aspiration. So bone marrow aspiration, the most common site is posterior superior iliac spine, and if there is more than or equal to 20% blast, it is criteria for AMG. But in some cases, like if there is proven translocation 8, 21, translocation 15, 17, translocation 16, 16, or inversion 16, so we call it as AML without the marrow blast cells counted. The on bone marrow aspiration, the OR rods are seen, OR rods can be seen, which are eosinophilic cytoplasmic granules, needle shaped. A flow cytometry is CD13 and CD14 positive, as we have seen in the previous slide. In M7 variety, it is CD41, CD61. These are the OR rods. Cytogenetics, we can check for the mutations like FLT3 gene mutation, CEPPA mutation, NLM mutation, SICKIT mutation can be seen. The other investigation, like we will do CBC, HP, platelet count. Then we will do chest X-ray for, because there can be lymph node involvement in the chest. We will do echocardiography. We will do kidney function test for tumor lysis syndrome. Okay. So that come to treatment, the drugs are cytarabine, anthracycline, daunorubicin, and idarubicin. The most common combination is of cytarabine and daunorubicin. If there is remission, we will go for allogenic stem cell transplantation. So we will just note the facts about MPL. It is having max number of OR rods associated with PML RARA fusion gene is formed due to translocation 15, 17. So the OR rods, when the cell die, will come into circulation, and this is responsible for DIC. So come to treatment, we have all trans-retinoic acid. This causes differentiation of cells. So OR rods are reduced. So DIC is also reduced. But the side effect is, since it is causing differentiation, it can lead to differentiation syndrome. Differentiation syndrome, which can lead to death in these patients. So we give steroids for prevention. So to summarize, AML is more common in old age. FEP classification, we should remember M3, M5, M7. All rods are best in acute promyelocytic leukemia. Criteria is 20% of blast, except for proven translocations. The treatment is cytarabine and daunorubicin. For APL we use Entra. Thank you. I hope you liked the video. Thank you for watching.